I hope you have seen my previous videos of ECG. So now today will talk about arrhythmias. First of all, we talk about ventricle premature beat, also called ventricle ectopics. Let's see. This is a normal recording. Okay. Suddenly a focus comes from the ventricle and we get a bizarre shaped. It's an abnormal shaped recording, but we use the term as bizarre. This is the isolated ventricle ectopic or ventricle premature beat. Okay. Nothing worry about it. Suppose we get like this. That means we are getting one normal, one ectopic, one normal, one ectopic. If we get like this, that is bigeminy. It is classically seen in digoxin therapy. It's a benign condition, nothing worry about it. Suppose we get like this, normal, ectopic, ectopic, normal. So we are getting two ventricle ectopics together. This is known as couplet. This is a major concern because this can go into ventricle tachycardia any moment. Now, let us see one more recording. Normal beat, ectopic, 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 normal beat. So here we are getting three ventricle ectopics in continuation. This is known as ventricle tachycardia. So in any recording, if we get three or more than three ectopics in continuation, we call as ventricle tachycardia. It can be a dangerous condition because this can go into ventricle fibrillation anytime. Ventricle fibrillation is just like nothing but another name of cardiac arrest. Okay. But one thing is there, in ventricle tachycardia, patient may have normal BP or patient may have low BP. If in ventricle tachycardia patient has low BP, the treatment of choice is always DC shock. Okay? But if patient has stable BP, then we can go for drug therapy. Drug therapy is usually lignocaine. Is the one drug which is most widely used drug in ventricle arrhythmias. The other drug that we can use is even sotalol also. Right? So what we remember, if BP is low, DC shock, if BP normal, lignocaine. Now we talk about bradyarrhythmias. In bradyarrhythmias, the heart rate is less than 60 per minute. Now, bradycardia, it can be physiological also. The physiological causes are athletes, sleep, an elderly person. But otherwise, pathological causes of bradycardia are race, intracranial pressure, deep jaundice, drugs like beta blocker, but a very, very important point or important question, to be more precise, a new drug, ivabradine, is there. is a new drug, and this question will surely come to you in this exams. It's a new drug being discussed in all the conferences. Okay, then hypothyroid. Hypothermia. And of course, complete heart block. These are some of the causes of bradycardia. Now we talk about PAT, paroxysmal atrial tachycardia. Here the atrial discharge rate is between 150 to 220 per minute. Okay, and it usually has sudden onset, and it leads to sudden onset of palpitation. Usually patient has polyuria is usually associated there, and it's very common in the young ladies. So in this case, in acute attack, drug of choice is injection adenosine or esmolol. But remember, because they are both are short-acting drugs, so these drugs are used only in acute attack. But for prophylaxis, we use verapamil. We can use beta blockers. Okay, we can use amiodarone. Here I'll like to talk to you something about little extra pharmacology about calcium channel blocker. When we talk about, remember here primarily we are using verapamil. So in the first generation of calcium channel blocker, we have three drugs. One is nifedipine. It mainly acts on the peripheral arteriole. It is a peripheral arteriolar dilator. That's why we use this drug to control blood pressure. And all of you know that peripheral resistance is 1 by R. R stands for radius of the arteriole. Narrow the arteriole, many-fold rises peripheral resistance, and that lead to increased BP. So nifedipine is a peripheral arteriolar dilator. It reduces peripheral resistance, so BP comes down. As far as diltiazem is concerned, it has main action on the coronary artery. It dilates the coronary artery. That's why it is especially used in Prince metal angina. And as far as verapamil is concerned, it has action mainly on the conduction tissue. That's why it is used in arrhythmia, especially atrial arrhythmias. So now, with the basic fundamental of mechanism of action, you know why we are using verapamil in case of prophylaxis for PAT. As far as atrial flutter is concerned, atrial flutter, the atrial discharge rate is between 220 to 350. Typically in the ECG recording, you got sawtooth appearance. Sawtooth appearance we get, and of course they maybe have blockage of 2:1 or 3:1. That means if there are, suppose there are 300 atrial impulse which are coming to AV node, only 100 come down, so we'll call 3:1 block. Okay, and then we talk about atrial fibrillation, AF. In the AF, the atrial, remember, multiple impulses are coming from various foci in the atria, and the atrial discharge rate may be as high as 450 to 600. Now in AF, classical question, concealed conduction occurs. Concealed conduction occurs. What do you mean by concealed conduction? Let's learn the basic fundamental. Here is the AV node. Suppose 600 impulses are coming from various foci in the atria. So 600 impulses come to AV node and all of you know that AV node has the maximum refractory period in the entire conduction system. So maybe that most of impulse come and only 150 impulse are sent down from the AV node. That means 450 impulses have been retained or blocked at AV node, and this is known as concealed conduction. Right? Now the ventricle rate is 150. The ventricle rate is very high. That's why the commonest symptom of AF is palpitation. Number two, as there is no synchronized contraction of the atria, that lead to stasis of blood in both the atria, that predisposed to thrombus formation in both the atria, which can later on can have a embolic phenomena also. Moreover, as the ventricle rate is very, very high, so duration of diastole is short, and all of you know that 80% of the coronary filling occurs in diastole. So because the reduced time of diastole, coronary filling is reduced, the patient may develop pain chest. Moreover, as the diastolic period is very short, so let's say this is the heart, diastole period is very short, the amount of blood coming into the left ventricle is very less, and moreover atria is not contracting, the amount of blood coming into LV is drastically reduced. So in the next cycle, in the next systole, amount of blood entering the aorta is further reduced, so that lead to easy fatigability. Easy fatigability. Okay, so that's why these are the few symptoms what we get in a case of atrial fibrillation. Now, what are the important causes of AF? Remember, AF can occur in a normal person, especially after tea, coffee or alcohol. After alcohol, what the term what you use is holiday heart syndrome. The patient develops atrial fibrillation after a bout of alcohol. It can occur as congenital. Otherwise, it is common. Otherwise, the four major causes of AF are rheumatic heart disease, coronary artery disease, hypertension, and hyperthyroid. They are the four major causes of AF in very frequently asked question. Okay. Otherwise, it can occur in congenital heart disease. They may occur in endocarditis and all this thing. But you don't have to forget these four major causes. And in atrial fibrillation, our first aim is to reduce the ventricle rate. So especially in hyperthyroid, we use propranolol. Otherwise, in rheumatic heart disease, we prefer to use digoxin. Why digoxin? Because digoxin increases the refractory period of AV node. Of course, digoxin we can use in CAD and hypertension also, but in this we can even use beta blocker also. Okay. And one more thing, in atrial fibrillation, one thing which we are always very worried is clot formation. Remember, clot formation can occur in both left and right atrium. If clot formation occurs in left ventricle, clot will come here, then go to aorta. So it can lead to systemic embolism. But in case of RA, it will come right ventricle, go to pulmonary. It will lead to pulmonary embolism. The point to be noted, the embolic phenomena can occur in both right and left atrial thrombus formation. Okay. So this is all about atrial fibrillation. Now we talk about torsades de pointes. The main hallmark of this condition is prolonged QT. So anything which leads to prolonged QT can produce torsades de pointes. Now what happened? This is a normal recording. Okay. This is T wave. So this happened to be the QT interval. Beginning of Q to the end of T. And suppose we get like this. So here we are getting QT interval like this. So we are getting prolonged QT interval. And if the QT interval is further prolonged, then it will tend, in the later on, in the very advanced stages, it becomes like this. It totally stretched out. We get like this. It looks that the entire ECG is revolving around the straight line. Okay. And this is the hallmark of torsades de pointes. And any condition which lead to prolonged QT interval, like, so what are the conditions which lead to prolonged QT interval? Most important is hypokalemia. Otherwise, hypocalcemia, hypomagnesemia, class 1A drug, erythromycin, they all lead to prolonged QT interval, and they may induce torsades de pointes, which can ultimately go into ventricular fibrillation. Now one more thing which is not known to most of you, that class 1A drug, since they lead to prolonged QT interval, which can induce arrhythmias, that's why class 1A drug are also known as pro-arrhythmic drug. Why pro-arrhythmic? You know, class 1A is an anti-arrhythmic drug, but they have a quality of prolonging QT interval. So they in themselves can induce arrhythmias. That's why we class 1A drug like procainamide or and quinidine, they are also known as pro-arrhythmic drugs. Right? This is about torsades de pointes also, but remember, commonest cause of torsades de pointes in actual practice is hypokalemia. So whenever patient or torsades de pointes come to us, our first duty is to look for hypokalemia, and if hypokalemia is there, you have to give potassium, but potassium should never be given very rapidly. It should be infused very slowly. But in the meantime, what we can give immediately is magnesium sulfate. To treat a case, immediate treatment should be always magnesium sulfate. It prevents further damage to the heart. So this is about arrhythmias. And those of you who have not seen the previous videos on not only on ECG and all other topic, you can very well look into YouTube. We have posted all the lectures in the YouTube. And any particular topic you want to study, feel free to send the message to us via messenger. And we also plan to start a test and discussion. That means other than the lectures, we can discuss some questions also. Because some people have suggested, what is your opinion? Let us know that we can discuss some important questions, important drugs via MCQs, and we'll do discussion. So I'll be waiting for your message via messenger, or even you can mail me at my personal email ID. It is contact Dr. Bhatia at gmail.com, or rather even more convenient and easy for you, you can send me message at my WhatsApp number 9968 288 32. Okay, so you can send your comment, suggestion on my WhatsApp message. So we remain in touch with each other. So our aim is to give you best to the content. Thank you very much. So we're waiting for your message via WhatsApp. Thank you very much.